Welcome to this podcast from the Medical Journal of Australia. My name is Sally Block, the MJA's news and online editor. The MJA acknowledges the traditional owners and custodians on the land of which we work and live across Australia. This podcast was recorded on the lands of the Gadigal people of the Eora Nation. I pay my respects to their elders past and present. The MJA has recently published the Australian Clinical Guideline for Diagnosing and Managing Acute Coronary Syndromes 2025. Professor Jennings AO has a distinguished career as a cardiologist in clinical practice and was previously Director of Cardiology at the Alfred Hospital in Melbourne and Chair of the Division of Medicine. He is the Heart Foundation's Chief Medical Advisor. Professor Jennings is a co-author of the guideline and joins me now. What prompted you to write these guidelines?
Acute coronary syndromes are a really important issue for hospitalisation and death in Australia. Over 50,000 a year, probably 60,000. And it's an area where practice is evolving quite rapidly. And it's been some time since the previous guideline with the major advances like high-sensitivity troponin testing, better risk stratification, changes in therapy, antithrombotic therapy, systems of care are developed. All of this meant that we really needed to bring everything up to date, and this is a very comprehensive guideline that does that.
What are the most important things that they should take note of in terms of the new guidelines?
I think there are at least four big shifts. The first one is in our day-to-day management of people after acute coronary syndromes, where in line with international guidelines, we've set the target LDL at a lower level at 1.4 millimole per litre. A few years ago, that would have been quite challenging, but with the new tools we've got available to us, that's something that we ought to be able to easily meet in most, if not all, patients. The other three things, a much stronger emphasis on early and accurate rule out and rule in, particularly with the use of newer high-sensitivity troponin pathways. And there's a lot about troponin in the guideline and how to use it and how to make the most advantage from it. Another emphasis has been on risk-based decision-making, trying to determine who generally needs invasive management and who can be safely managed conservatively. And just as importantly, who can be determined very quickly in the ED or elsewhere as low risk and not take a lot of hospital resources or investigations to get to that stage. And I think very importantly at the systems level, we've got a big emphasis on integration of systems of care, things like pre-hospital assessment, regional networks, and equity of access across Australia. So I think those four things, the lower LDL levels, the early rule out and more accurate rule in, and clearer guidance on risk-based decision-making, as well as systems of quick care and equity.
Starting with the lower LDL, what does that mean for the clinician out there that's getting these tests done, or what should they be looking for?
It is really important to get LDL down effectively and quickly in anybody that's got atherosclerotic disease, and particularly after acute coronary syndromes. We know the benefits are there, and we actually know that the lower the better. So whereas in the past we aimed for an LDL of 1.8, we're now recommending 1.4. But if you get lower than that, that's not a problem. And the way to do that is through, of course, intensive statin use. If that doesn't get there, combination therapy. If that doesn't get you there, there are newer agents such as PCSK9 inhibitors where you can virtually dial up the level of LDL that you'd like to achieve, and they cause particular benefit to achieving that level causes people to be in a much better prognostic situation.
And the troponin, how do we work with that?
Well, we've had high-sensitivity troponins for a while. What's different now is it's much clearer in endorsing well-validated, accelerated diagnostic pathways, even a 0 to 1 or a 0 to 2 hour protocol where appropriate. It does always stress that the troponin results have to be interpreted in a clinical context. We know that there are lots of other situations where troponin can be increased by things like renal disease. So you've got to take account the symptoms, the ECG findings, the pre-test likelihood, all of that matters. Then you've got to know about the troponin test that you're using, because different assays are used by different laboratories, and you need to make sure that you know what the cut-off levels are for your laboratory. Another important thing as far as troponins are concerned is that levels can be different in males and females. And again, this is something that the guideline goes into in some detail, as well as many other issues where management of acute coronary syndromes might differ somewhat between males and females, particularly in terms of diagnosis, clinical diagnosis, and actions that follow.
And you mentioned about getting clearer on when intervention is needed.
Yes. Firstly, there's stronger support for identifying truly low-risk people early and avoiding prolonged hospital stays. Then we've set the bar higher as far as early action when there is identification through troponins, ECG, and other information on a blocked coronary artery. We're aiming to get that artery open within an hour. Now, that's challenging. That's more it's a more challenging target than some of the international guidelines, but we do know that the earlier the better. The earlier you are able to restore flow to the myocardium, the more likely you're able to avoid long-term consequences, particularly heart failure and other complications.
Obviously, since the last guideline was published, there's been a hell of a lot of progress and I guess in innovation or new techniques come into treating ACS. What in particular would you like our audience to know about what's the important parts of coming in terms of treatment?
There are major changes in the management of particularly non-ST elevated myocardial infarction and unstable angina, but the principles remain, and the guidance, I think, is a lot clearer in this very comprehensive guideline. There's a lot of emphasis on individualised timing of invasive management, balancing the risk of ischemia against bleeding risk with the use of antithrombotics, and comorbidities, which are, of course, so common in our older patients. And as I've mentioned already, it really aligns us with all of the major international guidelines, perhaps a little ahead in some points because ours is the most recent guideline and therefore was able to take in some of the more recent data.
So do you think these guidelines could attract international attention because it's the most up-to-date?
We certainly keep an eye on each other's guidelines, and in fact, new techniques for developing guidelines are evolving where we don't always start from scratch. We usually start with the best available. So that to that extent, evidence medicine practitioners, I'm sure, will be keeping an eye on this.
What's the most important thing to you about these guidelines? Like, what do you think should happen next?
I think what they show, because they're well aligned and harmonious with international guidelines, it won't matter where you choose to have your heart attack, you'll get roughly the same treatment, which will vary a little bit according to the health system and some local factors. In our case, it's related to our commonly patients have their heart attack in remote areas and the equity issues that we've talked about. We've lifted the bar a little bit on speed of action to 60 minutes. We've sharpened how we diagnose heart attacks, and we recognise, and there's great information on the fact that they're not all classical presentations and how we should deal with those. The medications, there's detailed attention to balancing bleeding risk with efficacy. Some of the terminology's changed a little bit, but not perhaps substantively. And it all comes down to, I think, the bottom line, which is speed, safety, and fairness in terms of making sure that everybody gets the best world-class treatment for their acute coronary syndrome.
There are 11 guidelines. So it's a short number, but I'm imagining that would have been a hell of a lot of work that has gone into creating them. Is that right?
Any guideline is a large exercise, particularly in such a comprehensive subject as this, because it deals with people before, during, and after their acute coronary syndrome. So it brings in issues like the importance of rehabilitation. It brings in the importance of pre-incident assessment and making sure that you are cognizant of what sort of risk this particular patient's taking. And then there are all the intricacies of hospital management, which of course is mostly for the ED physicians and the cardiologists, but it's an area in which there's also been significant change.
Could you elaborate on what that significant change is?
The changes in terms of technique with interventions, for example, that's not something that everybody needs to know about, but things are changing in the cath lab. And as we've already discussed, the importance of getting a rapid diagnosis using the latest tools, particularly high-sensitivity troponins, as well as our old friend, the ECG. And I should answer your original question. Doing a guideline is a major exercise. It requires expertise in the field, and it also requires expertise in assessment of evidence. There's a lot of activity in reviewing all of the existing guidelines and the evidence reviews that went to them, because you can assume the evidence is the same wherever it's looked at. And then assessing the grading of evidence as required by our NHMRC. And then we need our expert advisors, and they came from all fields, from everything from general practice, cardiologists, various other medical specialists, allied health people, First Nations, health experts, policy people, a whole lot of other disciplines need to contribute, and they need to turn that evidence into real life. What do you do when a patient presents to you at a particular stage in the before, during, or after an acute coronary syndrome? And that's where the practice points are very important in these guidelines. They're not just based on the evidence, they have a clinical nuance to them and a practical application.
So you mentioned that one of the groups that consulted was First Nations people. Is there anything different to their own particular needs?
There's lots of important considerations. Firstly, the importance of involving communities in protocols and processes. Secondly, making sure that the environment is culturally safe and that people feel comfortable being managed. And then there's the various clinical important things, like the fact that people from First Nations sadly present with their acute coronary syndrome are often quite younger. Quite a bit younger, and at ages where perhaps in the rest of the population there might not be consideration that was the diagnosis. Thirdly, we have common comorbidities, particularly diabetes and renal disease in people with First Nations heritage, and they need to be considered. It's important to treat the whole patient, of course, in a culturally sensitive and an appropriate way.
And what about cold communities? Is that something that have their different needs?
There are some differences in cold communities in terms of their presentations with cardiovascular disease. This was dealt with in the Heart Foundation risk prediction equation, which has the capacity for clinicians to make adjustments to people's likelihood of risk, which tends to be higher in people of South Asian heritage, a bit lower in people of East Asian and North Asian heritage. So there are things to take into account, not so much about the language, although of course it's very important to make sure that people have a good understanding of their condition, what's being done, what the options are, and that often involves bringing families into the story. But apart from that, there are definite clinical considerations which are dealt with in the guideline.
And are there any other areas you would like to highlight?
Looking at it again today, this is an extremely comprehensive and up-to-date evidence-based guideline. But you can have the guideline, but it's no good unless somebody follows it. and that's where implementation is key. And we're at that point now. There are some terrific tools available on the Heart Foundation website, and there's the My Heart, My Life program, which I think people would be familiar with, for which enrolment has been huge in the last few months. But it's not so much a matter of knowing what the evidence is, which the guideline will tell you. It's a matter of following it.
And can you tell us a bit about that program that's taken off that you just said, My Heart, My Life?
My Heart, My Life is a program that is intended to support people who have had a coronary event. It takes into account targets. It provides them with information. It provides them with support. It provides them with access to peer groups. And it's a very, very useful, I think, program which the people that have taken it up, as I said, there are many, but they're also finding it very, very helpful and supportive.
With the people who have been taking it up or who want to take it up, how can a GP refer them to that program?
It's just My Heart, My Life, which they can access. I believe it has its own website, but if not, through the Heart Foundation website.
Thank you to my special guest, Professor Garry Jennings. You can find more podcasts on our website at mja.com.au or wherever you find your podcasts. Thank you so much for listening.